Okay, so our group is going to be talking about Marfan syndrome. My group is composed by Adrian Ramirez, Armando Piedra, Gabriela Piedra, Josué Ruiz, Monserrat Macia, Winslow Quintero, Isabella Gianni, Gonzalo Falcón, and I, Shivani Lakani. So this is going to be the flow of our presentation. We're going to start with the introduction, following the description, the molecular genetics, clinical features, inheritance of Marfan syndrome, diagnosis, as well as the management, prognosis, and finally the conclusions. So I'm going to begin with the introduction. Marfan syndrome is one of the most common inherited disorders affecting connective tissue. It has a reported incidence of 1 in 3,000 to 5,000 individuals, including men and women of all races and ethnic groups. Connective tissue is what holds the body together and supports many of the body structures. However, in Marfan syndrome, the connective tissue is abnormal. And as a result, many body systems, including the heart, blood vessels, bones, tendons, cartilage, eyes, nervous system, skin, and lungs are impacted. Marfan syndrome is caused by a defect in the fibrillin 1 gene of chromosome 15. And this is the gene that basically encodes for the structure of fibrillin and elastic fiber, which are connective tissue proteins. Marfan syndrome patients are typically tall and skinny with long limbs, legs, fingers, and toes. We can see this in the pictures that they're usually skinny. We see the long limbs, the long fingers. It is almost always inherited, and it's known as an autosomal dominant, this inheritance. And this is because it affects both men and women equally, and it can be inherited from only one parent who has Marfan syndrome. Marfan syndrome patients typically have a 50% probability of passing the disease down to each of their offsprings. However, a new gene abnormality arises in 25% of the instances due to unknown reasons. Because not everybody with Marfan syndrome has the same symptoms to the same degree, it is also known as a variable expression genetic condition. Marfan syndrome is usually present from the moment the child is born. However, it is possible that it will not be diagnosed until adolescence or early adulthood.
Hi, my name is Gianni, and today I'll be going over the description of Marfan syndrome. First of all, I'd like to apologize for my voice. I'm a bit sick. Okay, so as we see in this photograph, individuals with Marfan syndrome are usually tall and slender, have elongated fingers and toes or arachnodactyly, large loose joints, and have an arm span that exceeds their body height. Other common features include a long and narrow face, crowded teeth, and abnormal curvature of the spine, such as scoliosis, kyphosis, or lordosis. There are also stretch marks not related to the weight gain or loss, as you would normally see who are not affected by Marfan syndrome. And they either have a sunken chest or a protruding chest, which can all be seen in the image. Here we have the intraocular lens dislocation, the ocular hypotension, the crowded teeth, the high and arched neck, the pectus crinatum or the extravatum, the disproportionately long arms, the stretch marks that we see here, the long fingers, the disproportionately long legs, the flat feet, as well as the tall, thin build, and the flexible joints, the scoliosis. And then there are other complications that can come with a Marfan syndrome, such as heart and blood vessel complications, such as aortic dilation, aortic aneurysm, aortic dissection, and mitral valve prolapse. And our nervous system can also have complications such as the dural ectasia. And then there's an increased risk of pneumothorax, which are also here. And people who are born with Marfan syndrome may not notice their features right away. They can appear later in life or at any age. And some people have many characteristics at birth or as young children, it just depends. And usually the aortic enlargement occurs as a teen or even an adult. Now, Marfan syndrome is affected by fibrillin. So there's a mutation on the fibrillin 1, which the fibrillin gene, which is on the 15th chromosome. And so one of the things that are affected is the reduction of the amount of fibrillin 1 protein produced by the cells. The structure and stability of the protein are affected. The transport of fibrillin 1 protein is also impaired, and there's a decreased production and quality of connective tissue. Now, the connective tissue affects the heart, the lungs, the blood vessels, the nervous system, the skin, the skeleton, the eyes, which are all seen throughout in the image. Specifically, the skeleton, as I mentioned before, affects the long bones, such as the arms, the fingers, the legs, the toes. They're tall and slender. They have the curvature of the spine, the protruding chest. And then when it comes to the eyes, they're usually either slightly higher or lower, shifted to one side. They suffer from nearsightedness, and they can also have retinal detachment. The heart and blood vessels can also be abnormally large, and this is present in about 75% of the cases. Then for the nervous system, it can be weakened, such as the connective tissue around the vertebrae, and the bone can wear away in that area. And there are various complications, as I said earlier. As for the description, to add more to the description, Marfan syndrome is caused by the mutation of the fibrillin 1 gene, as I mentioned, which is located on the 15th chromosome, and is in control of fibrillin. Now, fibrillin is an important part of the connective tissue, as I mentioned previously before. And without the mutated gene that causes Marfan syndrome, there are large amounts of fibrillin in the bones, in the heart, and in the ligaments. But people who with Marfans lack this fibrillin, which causes their ligaments to abnormally stretch. And it is typically inherited from one's parents, and is an autosomal dominant genetic disorder. And it can affect men, women, and children equally, and it can be found in all races and ethnic backgrounds. And as I stated earlier, some of the complications are mitral valve prolapse, aortic dissection, retinal detachment, fibrillin 1 mutation, arachnodalia, nearsightedness, and scoliosis.
Now we're going to be talking about the molecular genetics of Marfan syndrome. So, as previously mentioned, it affects the FBN1 gene, and the mutation is located at the long arm of chromosome 15, region 2, band 1. It has 65 exons, which are basically the sequence of DNA present in mature messenger RNA. And these exons span 200 kilobases as well as 5 domains. And the largest region takes up about 75% of the gene, and it is composed of 46 epidermal growth factor repetitions. The majority of the Marfan syndrome cases are associated with this mutation. EGF repetitions are cysteine-rich regions discovered in the epidermal growth factor protein, and typically patients are missense, and a missense mutation basically happens when just one base pair is changed. Therefore, a different amino acid is substituted in the resulting protein, and they have a dominant negative effect, meaning a mutation basically develops that causes a gene product to have a negative impact on a wild gene type product, which is also known as a gene in its natural form. And the amount of fibrillin 1 in the extracellular matrix is found to be less than 35% of what is predicted. Variants have been discovered in similar phenotypes. These similar phenotypes include ectopia lentis, Spritzen-Goldberg syndrome, and mass phenotype. Ectopia lentis is basically a condition that affects the position of lens. Spritzen-Goldberg syndrome is a rare genetic disorder that causes craniofacial abnormalities, skeletal abnormalities, neurological abnormalities, intellectual disabilities, among other things. And mass phenotype is a similar condition to Marfan syndrome because it also affects the connective tissue. And it also has like a similar mutation dealing with fibrillin 1. And relatively recent findings from 2004 are that the Marfan syndrome type 2 gene, TGFBR2, was discovered at the short arm of chromosome 3, region 2, band 4, subband 1. And fibrillin 1 and transforming growth factor beta signaling in the extracellular matrix have been linked in many studies. And the discovery of TGFBR2 mutations in people with Marfan syndrome type 2 offer a direct proof of this link. And here we basically have a depiction of most of what was mentioned. This is chromosome 15. And here you see where the mutation takes place. And then below here, you see how 75% of the gene is taken up by the calcium binding EGF-like domain. And you also see the TGF beta binding domain, as well as the hybrid domain, the cysteine domain, the EGF-like domain, the proline-rich region, and the glycosylation.
Hi, I'm Gabriela Piedra, and I'm going to be talking about the clinical features of Marfan syndrome, which is one of the most important things to look at when looking at genetics and trying to make a diagnosis. That specific correlations between the major and minor criteria is to make a diagnosis, including these clinical features, is going to be talked about when Josue gives the diagnostic presentation. So let's get started. So the clinical features of Marfan syndrome cause many different symptoms related to different parts of the bodies. This can include cardiovascular problems as well as skeletal problems, eye problems, pulmonary problems, and other problems. And we're going to go one by one now to really point out the specific features in each of these areas. So when looking at the skeletal system, the most important thing to look at is the marfanated body habitus, which is the tall appearance as well as long arms and legs, as well as arachnodactyly, which is long and thin fingers and toes, as well as pectus excavatum, where that's where the chest sinks in, kind of looks like this, and then you have pectus carinatum, with the chest sinks out. Then we also have scoliosis and flexible joints. To the right, we have a very, very good diagram that really explains everything and points it out, as well as featured pictures in the following slide. So here we see the scoliosis of the spine, we see the pectus excavatum and the pectus carinatum, which we see right there. So now we're going to look at the ocular clinical features. The most important when it comes to Marfan syndrome is retinal detachment, which is also known as lens dislocation. On this picture to the left, at the bottom right, we can see there where the lens is being dislocated from the retina. And then I found this very good picture to the right, where it really explains what happens to the patient if they have this retinal detachment. So to the left, we see the starfish with normal vision. But on the right would be how the affected individual would look at it, with these little dots as well as a kind of like a shadow on the borders of their vision. Then now we have the cardiovascular features, which include dilation of ascending aorta, which is when a blood vessel wall becomes weakened or damaged, as well as dissection of ascending aorta, which is a tear that occurs in the inner layer of the aorta. These things can cause aneurysms, ruptures, as we said prior, dissection, and these features are very important because they can be the most deadly. I'm not the most deadly or most impactful features that can be seen with Marfan syndrome. Then here we have the pulmonary features, which include Bulle, which leads to pneumothorax, emphysema, which is a lung condition that causes shortness of breath and sleep apnea. To the right, we see the Bulle, which we can really look at it. I'm not sure if you can see my cursor in the recording, but if we look at our right, that little U-shaped line, that is what marks the Bulle in this x-ray. Then continuing with the pulmonary features, we see unhealthy alveoli and alveoli impacted by emphysema, as well as pneumothorax, which is a sudden collapse of the lung, which we see on the patient or the diagram's left lung. So what other features can we see? We can see the narrow palate, which it crowds the teeth. We can see downward slanted eyes and stretch marks. So this is a case 1 that I found where this patient presents with 2 features of Marfan syndrome. He has the down slanting of the eyes as well as the narrow palate that is also high arched in many patients. Then now we have case number 2, which we see on the patient's left eye, they have a drop of the upper eyelid. Here we see 5 important features. We see the tall stature with the long arms. We see the long fingers. And then in C, we see a positive Steinberg's sign, which is a test done to diagnose Marfan syndrome. And in this test, you fold your thumb into a closed fist. The test is positive if the thumb tip extends from the palm of the hand. And then you see the pectus carinatum, and then the high arched palate, which we saw prior. And then here I have one diagram and one picture to help you really put together all these clinical features of Marfan syndrome. This diagram is an easy way to remember important clinical features that we can be tested on of Marfan syndrome, as well as just to remember them. And then I put Michael Phelps because he's someone that is very well known that is said to have Marfan syndrome, even though he has denied it in the media priorly.
Hello guys, my name is Armando Piedro. I'm going to be talking about the inheritance of Marfan syndrome. We can see that Marfan syndrome is a autosomal dominant disease. In a normal autosomal dominant disease, we see that the parent, inherits a disease from just one affected parent. The other parent has nothing to do with the disease, no family history of anything, but unfortunately, one parent has the disease. We can see that Marfan syndrome is actually a mutation in the FNB1 gene, and unfortunately, the the child inherited that mutation and they were born with the disease. Here we have a normal Punnett square of a autosomal dominant disease. Here we see the affected parent and a normal parent. We see that they have a 50% chance of having a child with the Marfan syndrome disease. Here we see a small pedigree just showing you like the basics of everything. We see that a parent is affected, the dad is affected, and the mom is unaffected. They ended up having 2 children with Marfan syndrome and 2 children without. This is the average that we would get, 50-50 average. I'm going to show now a pedigree on the next slide that shows the variations in it. We can see that Marfan syndrome is actually a disease that shows reduced penetrance. So this shows that not everyone will get the same like strength of disease, and everyone with Marfan syndrome will have like very different clinical features. We also see that it has a delayed onset, so we can see that later on in life, the symptoms of the disease could start showing up. You may not see them through your childhood, you may not see them throughout your life, but at one point or another, you start seeing symptoms. And again, with the reduced penetrance, we see that some people may not get much symptoms. Some people will get a lot of symptoms. And last thing to mention is autosomal dominant inheritance is the case for 75% of Marfan syndrome cases of the normal pattern of inheritance. All right, so this is the pedigree I was talking about. Here we see a first generation, we see an affected parent. They had 6 children in the second generation. 3 of them had the disease, while they had 3 children without disease. So here we see the exact 50-50. What do you see here in the first child? She actually went on to have 4 kids, and only 1 of them had the disease. So we had 25% of the children had Marfan syndrome. So you can see how this pattern of inheritance could vary. You may end up having 0 kids with the disease, or you could have all 4 of your kids, or all 6, or all 7 of your kids with the disease. But it could vary, but the normal is 50-50. And that in medicine is a big chance of having it happen. That's not a small percentage. All right, so here we see the second form of inheriting Marfan syndrome, which is not really a inheritance of Marfan syndrome. It can be caused by de novo mutation, which we see just a random occurrence of the disease out of nowhere in a family. This accounts for about the other 25% of cases of Marfan syndrome. We see a healthy dad and a healthy mom have a child with the inherited mutation. This happens spontaneous, randomly, and in Marfan syndrome, it causes a very severe form of it. We see children die at a high rate at the age of 1. In a pedigree chart, we would see just a blank for the disease, and then just a random mutation there, and that would be a de novo mutation. This occurs due to an alteration in the parents, in the mom's egg and the dad's sperm, would be an alteration in the genes. Normally we carry about 70 de novo mutations I was reading on, and unfortunately, sometimes you could inherit a mutation in the FNB1 gene, which could cause Marfan syndrome, and this is how this occurs. Like I said before, it is a very severe case, and we see that a lot of children die under the age of 1 when they have de novo mutated Marfan syndrome. Thank you guys for listening to my speech about the inheritance of Marfan syndrome.
Okay, good afternoon. So right now I'm gonna talk about the diagnosis of Marfan syndrome, and in order to properly diagnose Marfan syndrome, we need to take into account nosology. It's called the GENT nosology, and it's the current standard for the diagnosis of Marfan syndrome. And this criteria is divided into two parts, the major criteria and the minor criteria. And genitology is important because it's 95% accurate in diagnosing Marfan syndrome. And the gens criteria is gonna look like this. I'm not going to use this slide to explain the gen criteria because it's too complicated, and what I did is I divided it into systems. So I'm gonna start now with the skeletal system, and as I said, it's divided into criteria, and I'm gonna start with the major criteria. And in order to diagnose Marfan syndrome, we need to take into account these signs and symptoms. And the first one is pectus carinatum. Second one, pectus excavatum requiring surgery. Wrist and thumb signs, scoliosis of more than 20 degrees, or spondylolisthesis. Reduced extension of the elbow of less than 170 degrees, and medial displacement of the medial malleolus causing pes planus. The minor criteria are less pectus excavatum of moderate severity, joint hypermobility, high arch palate with crowding of teeth, and facial appearances. In the ocular system, we're gonna have only one criteria. It's gonna be ectopia lentis. Now, the minor criteria are gonna be hypoplastic iris or hypoplastic ciliary muscles, causing decreased meiosis. Second, abnormal flat cornea, and lastly, increased axial length of lobe. And in the cardiovascular system, the only two major criteria are gonna be a dilation of the ascending aorta, with or without aortic regurgitation, and involving at least the sinuses of Valsalva or dissection of the aorta, of the ascending aorta. Now, the minor criteria are going to be three, which are mitral valve prolapse with or without mitral valve regurgitation, dilation of the main pulmonary artery in the absence of vulvar or peripheral pulmonary stenosis or any of the obvious causes below the age of 40. And the third one is calcification of the mitral annulus below the age of 40, or dilation of or dissection of the descending thoracic or abdominal aorta below the age of 50. The next slide is interesting because it's a case report, and it's important because it aims to highlight the importance of physical examination in the initial management of these patients. Now, the case follows like this. A 33-year-old man was admitted to the emergency department of a district hospital with chest pain and back pain associated with vomiting. 20 hours after symptoms onset, and initial physical examination revealed an aortic systolic murmur and musculoskeletal morphologic abnormalities compatible with Marfan syndrome. Now, given suspected aortic dissection, a transthoracic echocardiogram was immediately performed, which showed an extensive intimal flap originating at the sinotubular junction. He was transferred to cardiothoracic surgery department of a referral hospital, where he was treated by a bento puncture. Now, a brief review follows on the diagnosis and treatment of the ascending aortic dissection and its specific nature in Marfan syndrome. Next picture is super interesting. Why? Because it's the same patient, and this image was captured in the cardiology after clinical observation. And here we can see the ascending aortic aneurysm. Now, in this case, careful physical examination during initial assessment raised the suspicion that this patient was a high-risk group of aortic dissection. Thus, avoiding unnecessary any lengthy exam and the diagnosis requires emergent surgical treatment, as we can see. And so direct contact with real time between those making in the diagnosis and the surgeons is essential, as well as protocols governing immediate access to a surgical center. And yeah, they could diagnose him and they could treat him. I'm sorry about that. Pulmonary system, minor criteria is gonna be apical bleeds. Some people don't know what apical bleeds are. Super simple, in the top of the lungs. And then next minor criteria is gonna be spontaneous pneumothorax. Why? Because of the apical bleeds. These air bleeds are sometimes burst, allowing air to leak into the space surrounding the lungs. Spontaneous pneumothorax. Minor criteria for skin and integument are gonna be stretch marks, and they're not associated with marked weight changes or pregnancy or repetitive stress, and also recurrent or incisional hernia. Vedura. This is gonna be a painful sign and symptom. Is gonna be lumbosacral dural ectasia, which refers to a ballooning or widening of the dural sac, which can result in posterior vertebral scalloping and is associated with herniation of the nerve roots sleeves. Grade 1, we can see a little bit of that lumbosacral dural ectasia. Grade 2 is gonna be a little bit more severe, and grade 3 is gonna be bad, as we can see in those pictures. Patient with dural ectasia may present with low back pain and radicular pain in the buttocks or legs, leg weakening or urinary incontinence. And in Marfan syndrome, dural ectasia has been observed in 60 to 90% of the patients. Okay, the dilation of the dural sac is almost always in the lumbar region. Family and genetic history is gonna be important. Major criteria are gonna be having a parent, child, or sibling who meets these diagnosis criteria independently. Secondly, obviously, a presence of a mutation of FBN1 gene known to cause this Marfan syndrome. And then a presence of a haplotype around FBN1 inherited by descent known to be associated with unequivocally diagnosed Marfan syndrome in the family. Lastly, the lab tests, which are gonna be essential for diagnosing and confirming the diagnosis of Marfan syndrome with the gens nosology, are gonna be FBN1 sequencing, FBN1 deletion / duplication analysis, TGFBR1/2 testing, and obviously panel testing. This is, as I said, an important criteria. This is the standard of diagnosis, and the criteria, as I said, divided in two parts, major and minor, and is 95% accurate in the diagnosis of Marfan syndrome. Also, we know, I forgot to say this in the beginning, we know it's 90% accurate because when we compare the diagnosis used with the gens nosology with the lab test, it gave us a 95 accuracy in the diagnosis of Marfan syndrome. Now I'm gonna leave you with the management of Marfan syndrome.
Good night, my name is Winslow Quintero. Today I'm going to speak about management of Marfan syndrome. While there is no cure for Marfan syndrome, treatment focus on preventing the various complications of the disease. The patient will need to be checked regularly for signs of the progressing disease. To accomplish this, in the past, people who have Marfan syndromes often die young. And with regular monitoring and modern treatment, most people with Marfan syndrome can now expect to live a more normal lifespan. And depending on the signs and symptoms, a procedure might include Aortic repair, if the aorta diameter reach about 2 inches or if it is enlarged rapidly, a doctor may recommend an operation to replace a portion of the aorta with a tube made of synthetic material. This procedure can help prevent a life-threatening rupture. In some cases, the aortic valve may need to be replaced. Scoliosis treatments. When there is a significant scoliosis, a consultation with a spine expert is necessary. Bracing and surgery are needed in some cases. Breast bones corrections. Surgical options are available to correct the appearance of a sunken or protruding breast bones. These operations are often considered cosmetic pursuits. As a result, insurance may not cover the cost. Eye surgeries, if part of the retina have torn or comes loose from the back of the eye, surgical repair is usually successful. If the patient has cataract, the clouded lens can be replaced with an artificial lens. I will right now speak about medical specialists. Due to Marfan syndromes affecting different parts of the body, the patient may need to see a variety of medical specialists. Living with a genetic disorder can be extremely difficult for adults and children. Adults may wonder how the disease will affect their career, relationship, and sense of themselves. Moreover, they may worry about passing the defective genes to their children. Marfan syndrome can be even more complex for young people, particularly because the often inherent self-consciousness of childhood and adolescence may be exacerbated by the disease effect on appearance, academic performance, and motor skills. Marfan related specialties, there is genetics. A geneticist is a doctor who specializes in diagnosis and treating families with different medical issues that can include single or multiple birth defects, sensory deficits like hearing loss or blindness, learning disability and developmental delay, error of metabolisms, problems with growth. And there is cardiology. A cardiologist is a physician who an expert in the care of your heart and blood vessels. They can treat or help you prevent a number of cardiovascular problems. They can also specialize in specific areas such as abnormal heart rhythm, heart failures, or heart problems that involve Marfan syndrome. And ophthalmology is a medical or osteopathic doctor who specializes in eye and vision care. Ophthalmology differs from optometrists and opticians in their level of training and what they can diagnose and treat. Later, we have the orthopedic doctors, and sometimes called orthopedic doctors or orthopedic surgeons, are doctors who focus on caring for your bones, joints, ligaments, nerves, and tendons, the tissues that connect bones and joints. These parts of your body are also referred to as your musculoskeletal system. Many patients with Marfan syndrome has problems with their musculoskeletal system, and that is why they have to go to an orthopedic. And the most important and last, the genetic counselor. This counselor provides information, emotional support, and guidance to people who have been diagnosed with a genetic condition. And the counselor guide the family and say the different type of symptoms that Marfan syndrome have and the different type of treatment that that patient could have. Thank you for your time, and now I will pass you with my partner.
My name is Gonzalo Falcon. I'm going to be talking about the prognosis with the Marfan syndrome. So, in general aspects, it's very important to understand that as mentioned by my colleagues, the management of these symptoms and everything that is presented with this kind of syndrome is being very well managed lately. It's been a lot of technologies have been developed in order to alleviate the symptoms and get, bring these patients as closer to normal as possible. So all these surgeries and bracing and all these therapies that already been mentioned are examples that what technology and time have brought to the table and in the betterment of these people's lives. One thing to understand also is that many studies already been done, and it's not age, race, sex, the severity of the conditions or the comorbidities of it. It's actually access to private health insurance, to private care, and access to work. But as you can imagine, it's a little bit harder when you have a genetic syndrome to be considered to all kind of work. Patients now need a battery of specialists. It's not the classic ones. So now we're going to be included not only the cardiologists and the geneticists. We also will need therapy, counseling. We also will need the psychological aspect of it. We will need the eye care that we now can provide in order for them to be as normal as possible. And also realizing that because of the different kinds of how severe the syndrome is, it's very, very important to try to be as individual as we can. By that I mean individualized medicine, and it will be required like that in order for every aspect to be in a good look. Now, if we're gonna talk about numbers, we need to understand that within the last 40 years, this group of people, these patients, now live nearly twice as they used to. Okay, so we bring the population and the life expectancy from the late 30s, early 40s, all the way to the 70s and even late 70s. That's very important because those numbers are numbers that are just normal, are within range of the normal healthy population. So we're giving them that first step of the life expectancy to be that long. It's very important that all this again is because within the health community, within the health professionals, education has been gained and it's been put thought into. We have new technologies that we can better diagnose, better to know what's really happening with these patients, and all this technology that then bring all these new life expectancy and future to these lives. Yeah, as mentioned before, the psychological aspect is very important too, because now they're living full lives and everything. So you will see that normally when surveyed, they score less than the normal population in terms of the quality of life. Okay. So that's very important to keep in mind now that the prognoses are much longer. It's very important if we're going to keep talking about numbers that still today over 90% of the death of these patients are still related with the aortic problem, is still related with the heart condition that the disease present itself, that the mutation present itself. Many of the times, again, because of how the severity of it can go unnoticed until it's too late. So many of these deaths are just, we find it way too late that we can do nothing medically, or we just find it post-mortem. And that's a reality, still the reality today. The prophylactic monitoring is very important, again, because we need to treat pressures and everything, as already mentioned, because of how the condition present itself. And as these people live longer life, we now have a bigger and broader perspective of the full condition. We know how will this look geriatrically, with the elderly patients. We need to keep in mind that this part of the sciences and medicine needs to update their books and everything, because they will now have these kind of patients that are, that their line is not used to have, because they didn't have the life expectancy. And finally, with all this being said, we we are presented now with new challenges. Let's say, for example, one of the most I like is that they need a lot of counseling now because they're getting to a reproductive age and they're getting to this. There's no infertility within this syndrome, so we need to take care and have a great counseling and genetic counseling and counseling within everything, because it's not only the risk of passing down the conditions and the syndrome, is also all the challenges and risk that pregnancy, that all that process, actually, childbirth and all that process can put the mother on that amount of pressure. And again, we as a medical professional, we need to consider that they will have a full life. So we need to have a better and a most approachable counseling on all the things that are come to be. For now, I will pass the ball to our colleague Adrian, and I'll see you soon. Have a good day.
Okay, so now we would usually ask some questions to the audience, but since we're not presenting in person, I'm just going to go quickly run by the options and explain why the answer is what it is. So the first question is going to be, which of the following is not a typical feature of Marfan syndrome? So we have these four options here, and out of the four, I'm going to give you a second to answer. But out of the four, the option would be A. So people with Marfan syndrome are usually tall and thin with unusually long arms, legs, fingers, and toes. So the damage caused by Marfan syndrome can be mild or severe, as we've talked about in this presentation. So if your aorta, which is the large blood vessel that carries blood from your heart to the rest of your body, is affected, the condition can become life-threatening. So that from what I just talked about, it rules out B and D. Scoliosis is caused when ligaments in the spine are so loose they cannot firmly hold the vertebrae in place. And rapid growth in a child with Marfan syndrome can also make scoliosis, the probability of scoliosis increase. So that rules out C. So the answer here would be A, flattened facial profile. And we often associate a flattened facial profile with Down syndrome, okay? So now we're gonna move on to question number 2. Question number 2 is talking about what protein does Marfan syndrome affect? Now, throughout the presentation, we mentioned it, so I'm gonna give you a second. All right. The answer here is B, fibrillin 1. Fibrillin 1 is a protein present in the body's connective tissue. The genetic defect of fibrillin 1 leads to an increase in the production of another protein, which is the transforming growth factor beta, or TGF-B. It is this protein's overproduction that is responsible for the features present in a person with Marfan syndrome. Okay. We're going to move on to question number 3. Question number 3, which of the following inheritance patterns is most closely associated with Marfan syndrome? We've talked about this in the last unit, and we've touched on it on this presentation as well. I'm going to give you a second to answer. The answer here is D, autosomal dominant. This condition that we've been talking about, Marfan syndrome, is inherited in an autosomal dominant pattern. Which means one copy of the altered gene in each cell is sufficient to cause this disorder, unfortunately. We're going to move on to question number 4. So question number 4, if a parent has Marfan syndrome, what is the probability of passing this disease down to each of their offsprings? I'm going to give you a second to do a little bit of the math. So as we talked about, it's autosomal dominant the last slide, right? So it kind of correlates. So if you know autosomal dominant in pattern parents, you should also be able to answer this question. Most kids with Marfan syndrome have it because they inherited the abnormal gene from one of their parents. But Sometimes it happens in a child without a family history, right? Either way, each child born to a person with Marfan syndrome, male or female, will have a 50% chance of inheriting the abnormal gene, which makes the answer in this case C. Moving on to question number 5. So question number 5 is talking about which of the following is not included in the Gannett criteria for the diagnosis of Marfan syndrome, right? And we have the 4 options here. I'm going to give you a second to answer the question. So the answer here would be B. A systematic score of greater than or equal to 7 points and a family history of Marfan syndrome is sufficient for a diagnosis of Marfan syndrome. And then this is my last slide and the last slide of the presentation. We're going to be talking about, the concluding summary here. So really, all we have here is just a summary of what we've been talking about this whole entire presentation. Throughout the presentation, we've listed causes, treatments, life expectancy, stuff like that, and the overall impact that Marfan syndrome can and will have on someone who's diagnosed with that. And Winslow has talked about in this presentation the comparison between how it is affected, how differently a person can be affected depending on their age. For example, it's different if how a child versus an adult deals with a Marfan syndrome diagnosis. And there have been treatments and there have been medical breakthroughs on this front. However, nothing that can cure Marfan syndrome. So quickly, I'm just going to list off what we talked about this presentation. Like we've said, Marfan syndrome is autosomal dominant inheritance. That's the pattern it inherits. Just need one parent for an offspring to have the syndrome. Marfan syndrome affects elasticity of connective tissues. That is why it's so important when we've talked about scoliosis, right? So just keep that in mind. Now we're going to move on to the 1 in 5,000 births. This is kind of, excuse me, it's really, damn, cannot think of the word right now. Self-explanatory. There we go. In every 5,000 births, at least one child will have Marfan syndrome, which is really, really sad. It's important to note that it affects both men and women equally in all ethnic groups. So it's not X-linked, it's not Y-linked. It's really important to know that it's autosomal dominant inheritance. It affects men and women equally in all ethnic groups. This is commonly associated by a mutation in the FBN1 gene on the chromosome 15. We talked about this in the question slide. I believe Monserrat has also talked about this. Fibrillin 1, keep that in mind. That's most likely going to be the cause. And lastly, we have some clinical features or manifestations here. Tall stature with disproportionately long extremities, fingers, toes, and stuff like that. But that's about it for our presentation. Here is going to be the references. There's a lot of them, but that is it.